Hello, and welcome to the May 2022 edition of Urgent Care Town Hall, presented by California Urgent Care Association and sponsored by Cepheid. My name is Claudio Varga, and I'll be your host for today's program. The Urgent Care Town Hall, presented by California Urgent Care Association and sponsored by Cepheid, is a monthly virtual meeting open to anyone and everyone free of charge, where we share and discuss all things related to urgent care, both in California and nationally. The California Urgent Care Association is the state chapter of the National Urgent Care Association. If you are a member of UCA and located in California, then you're already a member of CALUCA. And we urge and invite you to become more involved with us. There's a lot going on, and we'd welcome your participation. For more information about CALUCA, please visit our website at www.caluca.org. We welcome your feedback and suggestions for future episodes of Urgent Care Town Hall and invite you to be a presenter yourself. Just mail us at info@caluca.org. A quick reminder that the annual Western Regional Urgent Care Conference presented by CALUCA is fast approaching and will take place in the breathtakingly beautiful city of Monterey, California, over the weekend of September 17th and 18th. This will be the premier urgent care conference of the fall, and the focus is on timely urgent care topics of importance to the Western region of the US. CALUCA would like to encourage all California members to attend, and we'd also like to extend an invitation to all our brothers and sisters from all Western states to come join us. So if you're from Oregon, Washington, Nevada, Arizona, Utah, New Mexico, or Hawaii, this is your excuse to come visit Monterey and see iconic destinations like the world famous Monterey Bay Aquarium and Cannery Row, play a once-in-a-lifetime round of golf at Pebble Beach, or maybe even take a side trip to Big Sur and Hertz Castle, which has just reopened. Bring the family and make some memories that will last a lifetime. For more details about the conference agenda, registration, and room reservations at the Hyatt Regency Monterey Hotel and Spa, please see our website at caluca.org. This event will sell out quickly, so please register and book your room today, and we'll see you in Monterey. We've got a terrific program today with a distinguished guest speaking on a fascinating topic. But first, on behalf of the board of directors and our membership, we'd like to thank and welcome Cepheid for their sponsorship of not just today's town hall, but the entire urgent care town hall schedule for the rest of 2022. Over a decade ago, Cepheid set the standard for innovation in automated molecular diagnostics, and they've never looked back. Today, Cepheid can boast of having the largest installed base of any molecular platform and is constantly innovating and evolving its capabilities to keep pace with today's shifting healthcare landscape. The Gen Expert system has been heralded as game-changing by healthcare leaders across the globe, enabling institutions of any size, from small medical clinics to urgent care clinics to high-volume reference laboratories and hospitals, to access the speed and accuracy of molecular diagnostics. Cepheid's growing expert test menu spans multiple clinical applications, including healthcare-associated infections, sexual health, critical infectious disease, virology, and oncology. Of particular value during the COVID-19 pandemic has been their PCR Plus system, which delivers speed, accuracy, and flexibility. Please visit cepheid.com today to learn more. Our special guest today will be speaking about a very important topic that is certain to be valuable to all urgent care providers watching. Dr. Brian Sun is an oral and maxillofacial surgeon based in San Jose, California. He is a faculty member at the University of the Pacific and Western University of Health Sciences, and a graduate alumnus of the UCLA Center for Oral, Head, and Neck Oncology Research. His areas of interest include dentoalveolar surgery, sleep surgery, orofacial trauma, pathology, and anesthesiology, with a multitude of journal, textbook, and reference book authorships to his credit. He is a lifelong clinician, researcher, and educator with interests not only in the clinical, but the scientific aspects of surgery, who remains comfortable with both teaching and researching maxillofacial biology. We're very fortunate to have him here with us today. Dr. Sun, welcome to the program. Please tell us about your passion for the specialty and why your information today is so valuable to urgent care providers.
Thank you for having me, actually. It's an honor to be with all of our urgent care providers from California on the west side. I think that the dental and orofacial trauma is one of the most profound traumas that we get from a variety of different methodologies, including just, falls or bike accidents and things like that. And I found that there's a great need for a lot of providers, including my urgent care colleagues, to help address that, because it's certainly not as well addressed as they could be, and a lot of providers tend to be a little bit more uncomfortable dealing with it just because of the dental. So, open. So, yeah, just like Mr. Varga mentioned, thank you for your very kind introduction. I'll be sharing my studies and my own experiences on management of orofacial urgencies and emergencies today. And as you've heard, that's me, oral maxillofacial surgeon. I'm currently here based at San Jose, but I do teach at the University of the Pacific and Western University. And I'm on staff at Stanford Regional Medical Center and Alameda Hospital, where I do perform a variety of surgeries of the jaw and then the dental regions. And I do have a small molecular biology, cancer biology background, so that's always something that I enjoy referring back to. And basically what I do is, I think the easiest way to think of an oral maxillofacial surgeon like myself as a jaw surgeon, right? So we can remove teeth because we do have our basis of training is in dentistry, but we do train at our ACGME medical residency out of trauma hospital. So most of our procedures tend to be more medical in nature, like where we drain and incise and drain orofacial infections. We do jaw reconstructions, jaw realignment for congenital problems. We do TMJ issues and treatments, and a big part is trauma. I think that was probably the most common surgery that I conducted in residency. So this is kind of the baseline. And then a little bit of a disclaimer, I tried to make this cut. I felt that whenever we have presentations on different types of medical procedures and recommendations, number one, I think that it's always important to follow your own medical judgments first, right? Always follow your gut feeling and make sure that you can tell if it's safe or not before performing any of these things. And then number two, I try to include the CPT and the ICD-10 codes because sometimes, the dental related and the oral related codes tend to be a little bit more complicated and a little bit more difficult to deal with. So I try to include that as a guidance, but by no means is this kind of an insurance specialty kind of lecture. So, I do advise you confirm that with your insurance specialist and your billing specialist, just to make sure that these codes are applicable to your current situation. So, just to start off with, I think it's important to remember that orofacial or jaw injuries carry high risks of cranial, C-spine, or airway injury. Some studies show that anything between 15 to 20% of people showing up with these kind of injuries have some kind of an airway or C-spine injury, which are admittedly a lot more serious than having a dental fracture or even a jaw fracture. So per your training, please always follow the basic BLS and ACLS principles. Sorry, I got a little the spelling error there. Always check airway, breathing, circulation first. Make sure the patient appears okay, they don't look septic or ill appearing, and then check for their loss of consciousness and alertness. I think a lot of our ER colleagues, they're very good at checking the ANO times 3, ANO times 4, and then of course monitor their blood pressure and pulse as well. And then anytime you see any kind of injured areas, it's always prudent to clean it out, irrigate it out with chlorhexidine or warm water, warm saline more so, whatever you have available with you at your clinic or your hospital. And then of course, any gross foreign bodies that you see embedded in there, as long as it's not like a stab wound or something that would cause, explicit bleeding from the area, try to remove any little particles. And then of course, because the injury is in the oral cavity, make sure that you can account for any loose or displaced teeth because they can be swallowed or aspirated. And then, orofacial examination is not too different from examining other parts of the body. You always want to monitor facial swelling, especially below the mandible or the submandibular region. Always want to make sure that the inferior border of the mandible is palpable. Like for this gentleman right here, you obviously cannot palpate that. And when this starts happening, you got to start worrying about the airway. This is a photo of Ludwig syndrome. I think you guys are all familiar with that, where the swelling gets grossly enlarged in the submandibular region, starts impinging on the airway, and then it becomes an emergency. And then kind of related to that, make sure you stay mindful of the airway position. You can have an airway displacement because of different swelling or infections, like you see in the picture. But the patient also may have a laryngeal fracture, which is also a big deal. And you've got to start thinking about cricothyrotomy in addition to addressing any gross fractures or injuries to the face. And make sure that there's no gross stridor or any difficulty, any seesaw chest rises when the patients come into your practice. And then tongue protrusion is another indicator of airway and or submandibular compromise. The airway, when it swells, it can certainly swell downward and plunge down towards the submandibular region, but it could also swell upwards and protrude the tongue and push the tongue out of the mouth. So if a patient can't keep the tongue in their mouth, if they start drooling, they can't swallow their saliva, that's also a very big indicator of something is emergently wrong, and the patient probably needs to be transported to an acute care hospital. And the floor of the mouth should be nice and flat like this, right? It should be soft. You should be able to see little vasculature, and it shouldn't be tender. And then when the patient has these kinds of swelling, it can impede interincisal opening, which is basically the opening between the upper teeth and the lower teeth in the front. You want to be able to fit 3 fingers between the upper and lower teeth. And if the patient can't do that, that's an indicator that he or she either has a fracture of some sort, or there could be an airway problem. It's not as strictly indicative of airway problem as the swelling and the floor of the mouth raises, but this is also a finding that should be noted on your notes. And then bony mobility, as with any fracture, there can be mobility across the fracture line. For this patient right here, you see he had a Lefort 1 style fracture where the fracture is horizontal through the entire maxilla. And when you suspect this, actually you can grab the bone just at the buccal, so the facial portion of the tooth, and then you can put a thumb right here and then an index finger along the palate. And when you try to rock this piece of bone, it will rock and it will move. So that's something, again, that you can note that can also cause further problems for the patient now. And then here, this is a mandible fracture, and you will feel mobility across the fracture segment on the anterior and the posterior mandible. So once you note all those potential airway issues and overall patient evaluation, you should always touch the patient's jaws and their teeth and their mouth. You definitely want to palpate across the buccal gingiva, which is this portion of the gingiva on the lateral portion of the teeth, upper and lower. Make sure that they don't elicit any explicit pain and there's no palpable step-offs. And then it can also give you an idea if there's abscess or swelling of that area. And then also make sure that the teeth themselves aren't loose. You can put 2 fingers, one thumb on the outside and then the index finger on the inside, and try to rock it forth a little bit just to make sure it's not loose or at risk of aspiration as well. And then this, that's a very obvious example of you having a step off. You can obviously feel that along the buccal or the outer membrane, the mucosal membrane here. This is a mandible fracture, and this should be referred out to a provider who can help address that. But fortunately, this person doesn't have any floor of the mouth swelling, doesn't have any facial swelling, and doesn't have any submandibular swelling. So it's not an airway emergency. So this can be referred out to on an outpatient basis to a provider. So I'm sure you're very, very familiar with these PO medications already, but I want to bring your attention to a couple of things. We always rely on hydrocodone or Norco or Panamol-3 or acetaminophen or ibuprofen, but I find that Choral at 10 milligram is also a very good alternative for PO medication, even as a pre-op dose if you're to try to drain an abscess or try to put fracture set it back together. Very, very helpful, and it doesn't contain any narcotics. And some of my patients actually prefer this over any Norco, so that's I think an indication of how well this works. For some of the more minor injuries in the oral cavity, if the patient can't tolerate narcotics very well, or they shouldn't be given narcotics, and they can't be given NSAIDs for some reason, A viscous lidocaine has been very helpful as well. You give them, you have them swish or place this viscous lidocaine, about 10 milliliters of it in any area that's in pain. Leave it there for 30 seconds and spit it out, and that can be helpful, especially if they have an abrasion or laceration there. And speaking of anesthesia, I think the regional block anesthesia for the facial cavity is very, very effective. Orofacial region and the oral cavity is very, very effective. The most common one that we always hear about is the this is not the most common. I'm going to get to that in a little bit, but one of the ones that we don't hear about as much is the infraorbital nerve block. The infraorbital nerve comes out of the foramen and the maxilla right here on both sides, and this gives pretty good anesthesia to the anterior portion of the maxilla, along the outside portion of the teeth, as well as the bone and then the nose. So that's pretty helpful. And I'll go over how to administer that in just a little bit. Posterior superior alveolar nerve block. You're trying to aim for the PSA, where the PSA arises from just right below the zygomatic arch in this area, and you can approach that through the mouth, and it profoundly anesthetizes the outside of the maxilla, lateral outside of the maxilla right here along this portion. And the injection should be directed just lateral to the second molar in the maxilla, as you can see in this photo. Ventral nerve block, it helps cover the anterior portion of the mandible. It's kind of on the outside as well. And then you can aim for that by aiming for this little foramen right here, that is between the two premolars. So you can kind of tell what the molars are by looking at how wide they are. They have this white chip with multiple grooves and multiple highs and troughs, basically. But when you see the teeth in front of it, which have two little hot mountains on them, little cusps on them, between the two premolars on the mandible is where the mental nerve is, and you can aim for it just straight on there through the mucosa inside of the mouth, and that gives pretty good numbing in that area. And then there's the nasopalatine nerve block. The nasopalatine foramen is right between the two central incisors of the palate. You might actually be able to feel it with your fingers, and just injection right into that area numbs the anterior palate pretty well. And then the greater palatine nerve block, you're aiming for these two foramina on the posterior palate. It's just medial to the kind of the second and third molar region on the palate right here as well. And that gives profound anesthesia to almost all of the palate, actually, except just around the nasopalatine nerve on the anterior. And then finally, this is the most commonly addressed nerve block. This is very, very helpful for any mandibular injuries. Inferior alveolar nerve enters the mandible and innervates virtually all of the mandible, including the teeth in the mandible. And this is a cross-section of the medial portion of the mandible. So you're basically, there's tongue sitting right here, and then the mandibular foramen is located right here, and then the inferior alveolar nerve goes into this foramen, stays within the bone to innervate all the teeth and the bone of the mandible itself as well. We'll go over how to administer that, but it basically numbs up or anesthetizes this whole portion of the mandible. It doesn't affect the condyle or the coronoid process, but it does do the body of the mandible. So this is kind of a 3D render of a mandible. And you can kind of see the mandibular foramen right in the ramus here. And the way I would approach it is I would have the patient open real wide, and whatever needle or whatever injection modality that you're using, I would use it to approach it from the other side of the mouth like this, and I would kind of hit the ramus right here. This is about 1 centimeter from the anterior border of the ramus. That's very helpful. You can palpate that with your fingers. And then once you hit the ramus, then kind of walk the needle carefully towards the back. So you kind of tilt the needle this way a little bit and slowly walk it back until the needle is almost parallel to the molars in this area. And then get the needle about 1 inch deep, so about 2 to 3 centimeters deep and then you'll be right at the inferior nerve by the mandibular foramen, and then give it about 5-10 minutes to take effect. And the patient should be pretty numb on that ipsilateral portion of the mandible right there. Sorry about the messy little drawing, and it's kind of hard to do that on the computer. Here's a little video. I didn't make this. This is from YouTube, but I thought it was pretty helpful. You see kind of the person approaching from the other side. This is an injector that they use. They're feeling the anterior border of the ramus with their finger here. They're a little bit further behind than I would usually do it, but you can do it about here. And then you insert about 20 millimeters, 20 centimeters, and then I would actually walk it back a little bit this way by tilting this injector that way a little bit, like he's doing or he or she's doing. And that gives pretty profound numbing of the area. Sorry. And then this is the infraorbital nerve block. Like we mentioned, it anesthetizes the maxilla, especially along the facial portion of the maxilla pretty well. And the way you would approach is this. You see the premolars on the upper. I find that premolars is always very useful for blocks, but for both the mandible and the maxilla, because on the mandible, the mental foramen is right between the premolars, and then the maxilla, the infraorbital foramen is maybe right between or maybe just slightly anterior to the two premolars. And you kind of put your finger intraorally, kind of flip the lip up, upper lip up a little bit, and then inject through the mucosa here and go about maybe 1.5 centimeters, and you'll be at the infraorbital nerve and inject your lidocaine in that area. This is another video where a dentist is doing that. And you can see this is the premolar right here, right? This has two cusps on it. He's right in the mucosa, right in that area. He injected, and then you want to be approximately parallel to the teeth. That's how you go all the way up to the infraorbital foramen. And then you can insert about 16 millimeters. That's what you want it to do. And yeah, that basically gives us pretty profound numbing over the mid face and then even the nasal alet. Yeah. Okay. After you have someone who comes with injury to the orofacial region, I find that a lot of providers ask about, hey, what's a good radiographic imaging modality to do it? And I always say, don't do plain film. That's because, as you can see right here, this is a CT scan, and you can see this fracture pretty well, right? And there might also be a fracture over here too, but this is really readily visible. And then this is what's called an orthopancography or panoramic X-ray. This is usually dental providers have this. I don't think a lot of urgent care or emergency providers have this, but this is also considered not quote unquote plain film because it goes around in a circle around the jaw to obtain this image. But again, it shows this fracture pattern pretty well. And this is of the same patient here and here. So this is very, very nice. But then let's say you do a plain film AP, a radiograph, and it's, I mean, you can't see anything, right? There's so many really dense, small bones anywhere in the facial region that, yeah, you can't see teeth, you can't see bone, you can't see condyle, nothing. So I do not recommend AP film because it's not very helpful and you're just exposing patients to radiation for something that's not really helpful. So CT if you can, if not, you know, maybe the dental or the oral maxillofacial surgeon can take panoramic or CT scan. Anyway, so let's say you have a patient who comes in with a dental fracture. The fracture pattern can be fairly varied, and there's a lot of different ways that you can classify it. And I'm going to be honest with you, a lot of my ER colleagues are very, very good at classifying dental fracture patterns, you know, class 1, class 2, class 3. But in all reality, it doesn't really matter. The only thing that really makes the big deal is what I call a rule of the crown. You divide the crown of the tooth in half. So if you have injury on the top half of the crown, that tooth is a goner and it's not savable. So you can't do anything with it. That tooth needs to come out. If you have, I'm sorry, I gotta revise that. If it's in the top half of the crown, it is savable. I'm so sorry about that. So that can be restored. You can send that kind of case to your local general dentist to get a filling done or restoration done or crown done, the tooth doesn't have to come out. But if you have injuries to the bottom half of the crown, like this area or around here or right here, then the tooth is not savable because there's just not enough crown structure for restoration. And that needs to be sent to an oral mouth surgeon like myself who can remove the tooth, do bone grafts, implants, other reconstructive modalities as necessary. So it's kind of easy for us to picture this crown. If you have a broken crown at the top, you can still wear this crown and this crown is still usable. But if you have a crown that breaks in the way bottom portion right here, then it's no longer a crown, it's a band, and it doesn't have any royalty to it. That's, I think, a good way to remember this rule of crown. And then basic dental pain protocol. A patient comes to you, says they have dental pain, dental caries pain, or dental fracture. I think what's really important to do is try to do a regional block anesthesia as well as anesthesia of the local region. Oftentimes, the teeth themselves are directly innervated by your cranial nerve, so they tend to be exquisitely tender, and doing both regional and local anesthesia is very helpful. And of course, provide the patient with PO pain medications. We discussed that a little bit earlier. And then you should consider topical antibiotics to help control oral flora so that whatever broken teeth doesn't incur any bacteria entering the tooth or the pulp inside of the tooth. And the good choice for that is chlorhexidine 0.112% for them to use twice a day. Home or PO antibiotic is not necessarily indicated. This is only should be done if you see a fracture or a large laceration in the oral cavity. Just an isolated dental fracture or tooth fracture doesn't necessarily need it. Only the topical antibiotic is sufficient. And then, of course, follow the rule of crown for the referral pattern. So again, tip, top half of the crown, referral to your general dentist. The bottom half of the crown or the root, referral to your oral maxillofacial surgeon. Okay, now flexible splinting for loose teeth. So some people, instead of just having just a fractured tooth, the actual tooth becomes loose, and that looseness can be because just the tooth is loose, or the bone that bears this tooth has been fractured around this area. So in these kind of areas, you want to split the tooth and or the bone together. I mean, if you see somebody with a wrist fracture, you want to split that together. Same thing with tooth or the alveolar bone, which is the bone right around the tooth. You want to avoid splinting it rigidly. So I've actually seen someone when this tooth was loose, they would put skin glue all across the teeth like this, and that holds that tooth in place there. But the problem with that is skin glue, once it hardens, it doesn't have any movement. It's very rigid. So this tooth, naturally, before it was displaced, it was having microscopic movement a little by little. But now that it's rigid, it's going to start resorbing the root, and the root's going to have trauma. So you should actually use a wire splint of some sort, and this wire should be about 24 to 25 gauge. One of the things that some providers like to do is they put the wire over the teeth like this. If this is the loose tooth, they put a wire at least 2 teeth down to the right, and then 2 teeth down to the left, and then make sure these teeth themselves are not loose. And you can use a dental composite, which works really well, but I know not everybody has dental composite lying around in their office. So you could use skin glue. Just make sure that the surface of the tooth is nice and dry, and this can be helpful for the tooth. But if the skin glue is not sticking too well, you can also put a bit longer wire like this as a base. I would probably use 24 gauge for that, and then use a thinner, like a 25 gauge wire, pass it around the neck of each tooth, wrap it around. So wrap the tooth and the wire together in a little formation like this. And again, if this is the loose tooth, you should encompass at least 2 teeth to the left and 2 teeth to the right, making sure that these teeth are also stable. If you see evidence of bone fracture in that area, like the local bone, then the splint should be kept on for 4 weeks. If only the tooth is loose, then the splint should be kept in place for 2 weeks. Okay, now I talked about the local bone fracture. So the local bone means that the bone is just that portion that's bearing the tooth. So it's called the alveolar bone of the jaw. So this would be an alveolar bone fracture, and this would be an alveolar bone fracture. And those can be dealt with just by splinting. That's very much different from a complete fracture. Like this is a complete fracture, right? And so is this, right? The fracture goes beyond the portion of the bone that's just bearing teeth. So I guess the equivalent in the orthopedics would be, this would be like a green stick fracture, right? You still have this portion of the jaw or this portion of the maxilla that is intact compared to here where the whole length or the whole height of the jaw is fractured. And in these cases, people will have mobility across the entire segment, the left and right segment, instead of just that alveolar piece. And these people will have difficulty. People will have difficulty opening their mouth. So here are some of the billing codes. I've included dental codes because, frankly, dental codes pay better. Just from, I know you're all providing a very essential service and very good service for our patients, but we should also be paid accordingly for it. So these are the medical codes for it. If your insurance or whatever insurance the patient works with doesn't accept the dental codes, but these should be dental codes that you should consider just because it pays better. But yeah, these are appropriate for most situations when you have tooth avulsion, loose tooth, or fracture of the alveolar portion. Okay, and then complete jaw fractures. I mean, I shared this picture with you a little bit before, but you will see mobility across large portions of the jaw. You may see the entire maxilla flip back and forth like we talked about, or we can see large movement of the whole mandible across the fracture line. It's not a good idea to try to definitively treat this in a clinical setting, right? It should be addressed in an operating room setting, but you could help reduce the bleeding and the pain by applying what's called a bridal wire. And this is kind of similar in concept to splinting teeth. What you need to do is, if this is the fracture line right there, you need to locate 2 teeth to the right and left of the fracture line that are both stable. Run a wire through one side and then make it come out the other side. Join them together and then twist the wires together and really tightly until the 2 fracture segments come closer together. That way, there's not as mobility across the fracture segment. It bleeds less, and it's a lot more comfortable for the patient. And it kind of serves as a good basis. If you were to refer this patient to an oral maxillofacial surgeon like myself, and the patient comes with this, it's a lot easier and less uncomfortable for the patient to undergo surgery to fixate this area. So, little video showing how to do bridal wiring. Look, as we can see, the person already has the wire through the space between teeth here and here, assuming that this is the fracture line there. And then they're just gripping the wire with either a hemostat or a Kelly. I think we do have wire drivers that exist that it's a little bit better to do this with, but you can do it with a Kelly, that's okay. And then just cut off any excess portion of the wire like that so that they're not basically sticking out of the patient's mouth. And then you see this stump of wire that's twisted right here. You want to curve that in towards the tooth so that the sharp portion faces the tooth and doesn't face the gums underneath, because that'll hurt and that will not be great. Okay. So kind of building on the basic dental pain protocol, here's the osseous fracture protocol. Of course, always, for these patients, I think that it's not a bad idea to have them take some PO pain medication before you do anything, just because, one, it hurts a lot, and if you give them some Norco, it actually also helps them calm down a little bit. Do regional block anesthesia and then local anesthesia also, just like before, and then perform whatever splinting that's appropriate for the occasion. So if it's just the alveolar jawbone fracture, then you do the teeth splinting like we talked about. If it's a complete fracture of the jawbone, do a bridal wiring like we talked about, and whatever you might be comfortable with for your comfort level. And of course, provide PO pain medication. And you should also give them topical antibiotics like before, like with the dental fracture, which is the chlorhexidine. And then when they have complete fractures or alveolar fractures of the jawbone, yeah, you should definitely give them PO antibiotics. And I'll talk about what antibiotics I usually like to use for these occasions. Lacerations. So if you have lacerations or soft tissue injury, usually they can be classified as two different distinct categories. If you have punctures, I mean, there's nothing really much to do unless there are fractures associated with it. But if you have a laceration, of course, you want to irrigate the area well. Chlorhexidine irrigation is pretty good, but saline works just fine. If you have laceration across the mucosa, you should use resorbable suture. And if it's isolated mucosal laceration without any underlying muscle components, just use a chromic gut. I think that lasts about 5 days to 7 days, which is just appropriate for the mucosa. If you do see any muscle tear underneath the mucosa or skin, of course, use things like Vicryl Polysorb, which is a polygalactin, lasts 3 to 4 weeks. I'm sure you guys are already kind of familiar with that. And then we all learn from a plastics rotation, skin lacerations, you should do that with monofilament, non-resorbable suture, because we don't want to create train tracks in the area or any scarring in the area with resorbable sutures, which have poor inflammatory profile for skin. Avulsions are kind of more complex version of lacerations, I would say. This patient had, you see the photo up here, that's from a dog bite. And I think I've been seeing that more and more often in children, unfortunately. Little kids who are like 3 or 4 years old, they're at the perfect height to be bitten right in the face by a big dog. So they tend to come with these injuries more often. And, you know, it's not always easy to, you know, fix this first, I mean, just immediately. But what's really interesting is that, you know, lip skin is very, very loose and very, very forgiving. So up to 1/3 of the upper or lower lip, if it's lost in this kind of fashion, you can actually burn it together and close it primarily, and the patient still doesn't have any problems. They could still have adequate oral opening. It might feel a little bit tight at first, but you know, the function-wise and even aesthetically, it's still doable and it still works. And whenever you have avulsions like this, you always want to worry about any kind of infection. So always do tetanus prophylaxis or consider, you know, rabies prophylaxis, because you don't know what these dogs or even sometimes people who bite these other people, what kind of flora they carry in their mouth. Always irrigate this area well. If it's up to 1/3, like we talked about, you can definitely try to attempt to close that. Just close the deeper muscle layers with the Vicryl or the longer lasting resorbable sutures like we talked about. And then the lip mucosa, you can close this from the gut. And then the skin, if there's any skin component, you can close that with Echelon or any nylon sutures. If it's greater than 1/3, then you probably need some kind of secondary reconstruction. So what I would say is, well, irrigate the area really well, remove any foreign bodies, of course, and then keep it moist. Dress it with Zeroform or some kind of, you know, Vaseline-containing dressing material. Put it in there, cover it up really nicely, and have the patient see, you know, either an oral maxillofacial surgeon or sometimes a plastic surgeon. And then these avulsive wounds, especially if they are a bite wound, you want to put them on augmentin or doxycycline. And this is per the guidelines for bite wounds from the American Association of Family Physicians, and that's very, very helpful as well. Again, coding. There are actually dental codes for laceration and avulsion of the lips and the oral cavity, so you can try using that as well. There are here the D codes, and of course these are the medical codes that you can use. Because of the size and location of the wound, there's a bunch of different codes, and you have to kind of try to match it as best you can according to the location and size, and try to put as comprehensive as a list of those as possible here. And then bleeding. This was kind of the favorite of the ED attendings at the institution that I studied at. That a lot of patients with or without blood thinners, they come into the ED and they say, "Oh, I got a dental extraction done and it won't stop bleeding." And understandably, it's not quite that simple to address it, but I think this protocol works 99% of the time. What I would do is if this is the area that's bleeding right here, I would irrigate the area out really well, make sure there's not any debris and really not old or nasty clots in there. And then I would inject all around that area like this with epinephrine containing local anesthetic. So lidocaine with epi is just fine. And then I would apply, while that's taking effect, I would have the patient bite down on some gauze, or maybe one of your assistants hold that area with gauze. And that gauze pressure has to be there for 10 minutes, per hemostasis protocol. And then after 10 minutes, you can remove that gauze very carefully. If you, just kind of roughly do it, it may cause rebleeding. And then you can pack that socket or that area with any gel foam or Surgicel or Avitine. Avitine works very, 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 very well, but it's also expensive. Usually, I think even gel foam is sufficient. I always use gel foam in my cases. And then once the gel foam is in that socket, I would close off over the socket in kind of a figure 8 pattern. I'll show you how that's done a little bit. And this kind of pattern will help keep that gel foam or Surgicel or whatever that's in there in that socket. And then I would use a resorbable suture, so like a chromic gut, like we talked about earlier, over that socket area. If you do have a fracture in that area, and that's why the patient is bleeding, then of course, splint that area, do a bridal wire or dental splint. Make sure you minimize movement and you bring the fracture lines close together as much as possible. If you have cautery and you can see an obvious bleeding vessel or obvious bleeding from the mucosa, you can use that as well. But sometimes it's kind of hard to use it just because, if it's way in the oral cavity or way down deep in the socket, it's kind of hard to reach into that area with these types of things. So I'll show you the figure 8 suture. Imagine that that's a socket right there, and you just basically go into the mucosa right here and come out the other side like that. And sorry, they're doing this a little bit slowly, but it's easy to see it that way. And then go across diagonally from the suture, the socket site. And you made that one crisscross right there. Go through right here. And then finally, now you got a nice little crisscross over the socket. You tie that down there, and then whatever material that you just pack the socket with, whether it be gel foam, whatnot, it'll stay. Okay, so going to infections. Orofacial infection can be a very, very, very serious problem because, like we talked about, it's very close to the airway. And airway is, as you can tell, ACLS protocol, right? Airway always comes first. So if somebody comes with signs of infection, or if you suspect an infection, always make sure that you check for fevers, nausea, dizziness, and low blood pressure. And you guys know this better than I do. I mean, you want to go with the sepsis protocol, right? You don't make sure they're not septic. Check the airway, look at the trachea, look at the Adam's apple, and check for the swelling below the inferior border of the mandible, because that can start deviating the airway. And then, of course, check for elevation of the floor of the mouth or protruding tongue. If you see any of these, I think that's worth calling an ambulance and have them go immediately to the nearest acute care hospital as soon as possible. So these, they should not even be treated in your clinic. But let's say somebody comes with swelling or infection, but it doesn't have any of these signs. One of the most common things that I see coming to the urgent care clinics is they have what's called a periapical. And what it is basically, this is a wisdom tooth right here, this A. And wisdom tooth, as you know, they oftentimes don't erupt fully into the mouth, and they have a little piece of mucosa that grows on top of it because it's not erupted completely. And below the mucosa, you start getting accumulation of bacteria and food, like you can see right here in this photo right here. So, and this leads to swelling, pain, and sometimes it could also prevent the patient from opening their mouth fully because it will inflame the masseter and the nearby muscles of the jaw. So this can actually happen without dental caries because this tooth doesn't have to have cavities or caries to have food or bacteria stuck under it and between this and the mucosa right on top. So when you see that, you could definitely do stabilizing treatments in the office. It's not very difficult. So when you see, what you can do is you can irrigate under this mucosal flap. Saline or chlorhexidine works very nicely. What I would do is I would put some of that in a syringe of some sort, or maybe a monojet syringe, direct the tip of the syringe under here and just irrigate really, really well so any food and bacterial debris come out. If you have the right instrument, you can use like a small blunt instrument to go under it and also try to divide that out as well. And then some providers I've seen actually what they do is they debride it and then they take some kind of a antimicrobial agent. They do sell specific like minocycline spheres. The brand name is Reston or Periapical, but those are kind of expensive and they're not very easy to find outside of like specialized dental stores. So you can actually just use a PO capsule of clindamycin. If you open it up, it has a nice powder of clindamycin, and you can pack that in this area after irrigating and debriding it so that it helps keep that area under control for a little while. And then once all these stabilizing measures are done, I would also recommend referring the patient to an oral maxillofacial surgeon to get rid of this wisdom tooth because yeah, you just debrided this area and you help to clean it out, but it will reaccumulate fluid and bacteria and there will have recurrence of the pericoronitis. So ultimately, this wisdom tooth should be removed to prevent that from ever happening again. I did again provide the dental codes for these treatments, but unfortunately, the CPT code, there's only one CPT code for all of these treatments because all of these are considered unspecified dental treatment, quote unquote, unspecified dental treatment. And the CPT code for that is this, and you need to provide your notes to bill for that. And then if you're a little bit more comfortable with surgical excision of mucosa, then what you can do is also called the gingivectomy or periapical. Gingiva just means the oral mucosa. So you basically see the mucosa here like this. You can lift that up with any kind of instrument. Here they're using like a lasso type of thing. You don't have to use that. You can use a blunt instrument. Just lift that up, and you can use a blade or a bovie, whatever you got, and just makes it cut like this. And then now the mucosa is gone, and that will help prevent impaction of food and bacteria. This is also temporary because the mucosa often grow back like this, but it will keep the patient more comfortable for a longer period of time than just debriding it. So you can definitely do that if you feel comfortable. Don't make the laceration the incision too far back, like over here, because the lingual nerve can run in here. So make sure that you are right up against the tooth that you can, right here, and that way you avoid injuring the lingual nerve, which gives sensation to the tongue on that side. So yeah, so definitely avoid going posterior, uncover the crown, and then you can definitely use cautery because this mucosa is often very inflamed, so it bleeds a little bit when you do that. One other ways to help prevent the bleeding is you can inject it with epinephrine containing local anesthesia, local pressure, or chemical cautery after the procedure. I mean, silver nitrate is very cheap and easy to use, so I've used it multiple times before. And then since gingivectomy is now a quote unquote surgical procedure, there is a separate medical CPT code for it. Okay, and then patients also come frequently with abscess of the orofacial region. And then as you can see, this lady has some swelling here, but the swelling doesn't reach below the inferior border of the mandible. This is just her neck fold skin right here. So you can palpate the inferior border of the mandible. That's a good sign. And you see an obvious break on the tooth, which can allow for entrance of bacteria into the tooth and to the surrounding bone area. And you see a little swelling. So that's a periapical, that's what we call a periapical abscess. It's because we call the tip of the tooth root apex, so it's periapical. And then something similar, you can also have periodontal, so it's periodont around the tooth. This happens because the gingiva around the tooth traps, it has bacteria harboring it, and it swells up like this. And then if you have that, I think that a lot of our ED or urgent care providers are comfortable just stabbing it and then draining out that way. If you want to be a little bit more fancy, I would do what's called the gingival flap incision or sulcular incision. The sulcus is the transition point between the tooth and the gum right here. And I would actually, if there's abscess right here, I would actually incise like this, and the two teeth to the left, two teeth to the right, and then introduce a blunt instrument this way. And the reason why this is more helpful is because this portion, the transition point between the tooth and then the gum right here, it's less traumatic, and you can actually potentially reach a wider swath of the infection area. So you can do that. And then if you do this, you can potentially even make vertical releasing incisions like this if you need to. You usually don't, but you can do that to get to the wider swath of the infected areas better and more easily. I don't think that we really need to visualize that. I mean, you can kind of see. And then, of course, here are the codes for that kind of treatment: incision drainage, removal of tooth, unfortunately, again, undocumented or unclassified dental procedure, and then put them on some antibiotics. Antibiotics that we talked about are usually what works really well is the beta-lactams, and augmentin is considered kind of the heavy-duty gun for this kind of thing, but amoxicillin and Keflex works really well. Patients with beta-lactam allergies, I think that clindamycin is no longer considered a first line just because of the resistance profile. It's getting more and more unfavorable, so you can use azithromycin or doxycycline. You can add on flagyl on top of this if you want to give better anaerobe coverage, but these are usually oftentimes sufficient after proper incision drainage. You feel like, oh my gosh, this patient is swollen, but I have to give him something before sending off to emergency or something. Metronidazole with levo gives good coverage as well. I think that gives a very common, fairly similar coverage to Zosyn, and that's a pretty decent start. But I wouldn't see this happening too often. Last but not least, we do occasionally see TMJ dislocations. It's because this condyle of the jaw where you have the joint, there's a big eminence in front of it. This picture kind of underestimates that eminence. Some people, this condyle can go over the eminence and be lodged right in this area right here. If that were to happen, I would perform regional block anesthesia here. I would put my thumb right over the molar region here, and I would press down and back really, really hard. That helps bring the condyle also back down and back. And the patient will freak out. Patient will be in pretty significant pain temporarily, unfortunately, temporarily, and the patient may bite you. So be careful. Make sure you have some gauze around your finger or something. Then here are the follow-up recommendations. Abscesses, usually 5 days. 5 days for skin lacerations if you do want to remove the non-resorbable suture. 1 week for mucosal lacerations because you use the resorbable suture, and then splints 2 to 4 weeks, and then tooth and bone vitality can be checked by your oral maxillofacial surgeon or dental professional at 8 to 12 weeks. Okay. All right, everyone. Any questions, any comments, any concerns?
Dr. Sun, thank you so much for that. That was That was a lot. That was really, really, really interesting. Really interesting. There
Thank
were
you.
a couple questions that got sent over, so we have a couple minutes. So if you don't mind, and you may have touched on
Yeah,
some of these things, but these are specific questions. So, um,
sure.
so kind of reviewing just the most common one is what's the best treatment for a patient who just walks in with their tooth in their hand? You know, they just got knocked out earlier that day. What would we do in an urgent care with that?
Yeah, that's a great question. I think the most important thing is to find out how long ago it was. So if a tooth came out of the socket and it's in their hand, it survives for about 30 minutes. So in adults, let me rephrase it. In adults, about survives for about 30 minutes. So if it's been past 30 minutes and you put it back, try to put it back into the socket, you're basically putting back a foreign body. So at that point, you got to tell them, hey, you know what, unfortunately, sorry, your tooth is dead. I would not be doing you a service if I put a dead tooth back in your mouth. You're probably going to need an implant. If it's a child, you got to determine if that tooth is a pediatric tooth, so like a milk tooth, or an adult tooth, because a child can have both, right? If it's an older child and they dislodge the adult tooth, I think that it's worth a trying to splint it in the same way that we talked about with the wires. But if it's a pediatric or the milk tooth, I mean, those teeth are meant to be lost. So even if you put them back in, it's not going to survive. So I would say, hey, this tooth should not be put back in. Please go see your pediatric dentist, and they'll put in a temporary prosthesis in the area that will help the adult teeth that are hiding in your gums erupt properly into the space.
Okay. And what if, people, there's the whole thing about putting it in milk or putting it in water or whatever. Is that does that change if the
Yeah,
patient presents with it in a container?
that does. Now, there's a lot of myths about what are good solutions to put teeth in. Milk is not a good solution. Water is not a good solution. The best solution is, Hank's solution, which is, I think, using tissue culture. But, I've never seen a patient carry that around in their pocket. The next best is saline, which is also not something very common that patients have. So the third best is their own saliva. So
Hmm.
if the patient came with you with the tooth still in their mouth, like they kept it under the tongue, or they kind of just put it in their cheek or something, then it might be viable up to 2 hours.
Okay.
So you can
Good
try
to
to
know.
replace it and splint it up to 2 hours. If it was in saliva, if they put it in milk or water, the tooth is gone in 30 minutes.
Got it. Interesting. Good to know. Okay. And then these two are kind of related. So you talked about some suturing. So two-part question. And you did mention some of this, but generally speaking, what anesthetic do you recommend for? I guess there's probably more than one, but if you have one that is most commonly you think that urgent care providers would have. So what anesthetic agent? And then what type of suture and size would you use for mucosal lacerations?
That's a good question. So anesthetic-wise, it would depend on if the patient has an infection or abscess in the region. If the patient doesn't have an abscess, lidocaine with epinephrine is shown to be very effective with very, very low instances of paresthesia. Some anesthetics, if you give it as a regional block in the facial region, it can lead to paresthesia of that distribution. So lidocaine does a very good job of minimizing that. And then, of course, with epinephrine, it helps it last a little longer and helps with hemostasis. If the patient is having some kind of infection or abscess, then you may use articaine or prilocaine, which are some of the other anesthetic agents that are available. I'll spell it out here. Right, or prilocaine. And these are, you should only give them as local anesthesia, not regional block anesthesia, for the same reason, right? You don't want these to cause paresthesia. And these are very helpful because their pKa is more favorable to the acidic environment of an abscess. So lidocaine, if you inject it around an abscess, it might not work as well, but these do a much better job. So I would use these. In terms of suturing mucosal lacerations, I would use either a 3-0 or a 4-0 chromic cut. Vicryl is also resorbable, but it tends to last a long time, like 3 weeks or so. And at that 3-week time period, patients, if it's in the mouth, patients start playing with the tongue with it, and it accumulates food and bacteria, and it's not very nice. But chromic gut lasts about 5 to 7 days. So before the patient can get too much debris on it, it dissolves away and it's gone.
Wonderful, wonderful. Thank you again so much, Doctor, for being here with us today. Hey, you're pretty close by. Maybe we'll get to see you in our Western States conference later in September. We'll send you some information. Maybe you can stop by, or we can find a slot for you to present in person.
Yeah, no, that'd be great. That sounds exciting. I didn't know it was in Monterey. I always wanted to go. You bring the family.
Yeah, absolutely, definitely. So speaking of just a reminder to everybody, the Western Regional Urgent Care Conference, which is our annual conference for CALUCA, will be in Monterey, California on the weekend of September 17th and 18th. And for more information, be sure and see our website at caluca.org. And once again, thank you, Dr. Sun, for spending this very valuable and informative time with us today. We really, really appreciate it. And thank you to everyone for tuning in and watching. Our next town hall will be Thursday, the 9th of June. So June 9th, 2022 at this 12 noon. So we'll hope to see you again there. So thanks, everybody, and see you later. Bye-bye.
Thank you for having me. Thank you.